Hello. Can you guys hear me? Wonderful. So thanks everybody for coming here. It's such a beautiful day. I was kind of worried that you might go outside, but I'm told this is the best time of the year to be here in Las Vegas. But either way, thanks for coming. So my task today is to talk about HER2 testing in metastatic solid tumors. And we are going to kind of talk briefly about the overall details of HER2 testing, and then we can feel free to ask questions as we go along. I don't see any mics placed, but we can figure things out of asking the questions and getting those answered. Okay, so let's start at the beginning. This is a program that is meant to be for US healthcare professionals. It's a sponsored program by Daiichi and AstraZeneca. And then, of course, I've been compensated for this program. And so the content is promotional activity and not a CME activity. Okay, so this is me. Just in case you don't know who I am, I'm the vice chair and professor of pathology at Emory University. And I do a lot of things mostly related to breast cancer. So the learning objectives for us today is to describe the importance of HER2 testing in solid tumors, recognize the evolving role of HER2 in tumors beyond the traditional gastric and breast cancers, and then explore the current guidelines of HER2 testing and scoring algorithms, and lastly, highlight key considerations in solid tumors. So, where do we start? Well, we start at the very basic, right? We first knew that HER2 was important in breast cancer. It was associated with high-grade tumors, associated with poor prognosis. And then as we started thinking along those lines, we realized that it's important in gastric cancer. And then slowly there were clinical trials in rectal cancer as well as endometrial cancer. And then now we are talking about multiple cancers in which HER2 is a prognostic marker. There's plenty of data to suggest the importance of HER2 as a predictive target in gastric and breast cancers. But is this limited to gastric and breast cancer? And the case that I'm going to make today is that we should be broadly testing HER2 in a wide number of cancers beyond breast and gastric cancers. So this is kind of the display of the HER2 expression. Note we are still talking about HER2 3+ expression. We are not talking about lower levels of expression in any shape or form. We should not be using the words low, ultra low, or any of those during this particular presentation. We are just talking about classic HER2 3+ expression. And again, there are reasons why we are not going to talk about. We can talk about it in private, but basically, the point that we are trying to make today is classic HER2 expression is seen in a wide range of tumors beyond breast and gastric cancers. So what's the incidence? As you can see on this slide, in breast is 10 to 20%, in biliary tract 4 to 13%, endometrium 4 to 30% almost, bladder again similarly 4 to 30%. Much lower in lung cancer, non-small cell, gastric cancer, as you know, around 3 to 15%, colorectal cancer, again, we'll talk about why the low expression is there. Ovary, 1 to 5%, cervix, around up to 15%. So as you can see here, there's a wide range of frequencies of HER2 3+ expression in a variety of cancers. So here's a polling question. I don't know exactly how the polling is supposed to be done, but you have the QR code. And you have the phones, so you're supposed to answer it on it. And I shall stop here to make sure that we get some answers on the board before moving ahead. Okay. So as results are coming in, so I'll wait for another second or two. Okay, so this is actually a very nice spread of answers. We Okay. Nice spread of answers. We have predominantly people looking at gastric and breast cancers. Some people also look testing in endometrial and colorectal cancers, biliary tree and ovary also coming up on the list. So really a wide range, as I just showed you in the previous slide, that all of these cancers seem to have HER2 overexpression. We see the same thing in your testing pattern. So this is really very good. Can we flip? Okay. So these are what the NCCN guidelines are. And for those of you who are not quite familiar, NCCN is a National Comprehensive Cancer Network where all the comprehensive cancer center people are represented, and they look at the current state of literature and decide on some guidelines. And so these are the guidelines which recommend testing across a whole bunch of cancers beyond breast and gastric cancer. And most of you already are testing in biliary tract, endometrium, cervix, colorectal, ovary. Bladder is another one that should be hitting our list fairly soon. Salivary gland tumors, we always talk about the ductal type cancers of the salivary gland, which mimic breast cancers to a large extent. So those would certainly be categories that we should be testing for. And then head neck cancer, also something that we should look at. So the important point I'm going to make in the next couple of slides is that we do not necessarily have a great overlap between the different molecular ways of looking at HER2. So what do I mean by that? As we know from breast and other cancers, we have immunohistochemistry for overexpression. We have amplification for looking at DNA level alterations, and then of course mutations for looking at small molecular alterations that occur. And then, of course, as no doubt you're all familiar with these technologies, we have the IHC or NGS in situ hybridization or NGS to look at amplification, and then NGS to look at mutation. And all of these technologies certainly are applicable for tissues, but also you can use ctDNA for looking at amplifications and mutations. The point is there's less than perfect overlap between these three technologies in terms of detecting alterations in HER2 expression. So there will be a large number of cases that have protein overexpression, but this may not be entirely reflected by amplification or mutation. So gone are the days when we basically said you need to have amplification and overexpression both in order to see a response. Now, as you will see, we are increasingly talking about only protein expression as sufficient indication for therapy. And that's a major shift in paradigm that has occurred within the last few years. So what's the data to support this? So here's some data that talks about, and again, it's a very busy slide, but it gives you an idea of the degree of differences between the alterations observed by these tests. So let's start with the commonest one, breast, immunohistochemistry, 10% to 20%. So the darker circle shows the lower limit, and the lighter circle shows the upper limit of what the frequency can be. Same thing for amplification, 13 to 23%, mutation 2 to 4%. So similarly, across the board, you'll see that there are wide variations in the frequencies with which you can see the alterations based on any of these three different assays or three different molecular alterations, overexpressions, mutations, and amplifications. The main important point is we are more and more focusing on the protein because novel therapies that are coming around are based on protein expression and targeting the cell surface protein using antibody drug conjugates of variety of sorts. So that's the reason the protein on the cell surface is increasingly becoming far more important than the DNA level alterations of mutations and amplifications. So here's the data from a large study which screened 1,126 tumors. 34% of them were IHC 3 plus or 2 plus. Similarly, there was, more importantly, there was no overlap identified between IHC 3 plus and HER2 mutant tumors. I think this is the kind of data that we are increasingly seeing across the board in multiple cancers. And this becomes important because these days NGS is so prevalent. People always love to do the ctDNA analysis, send it off to one of the commercial entities to look at the mutations that, or the amplification event, copy number alterations that may be identified. And you will miss the protein overexpression and the targeting of those patients with metastatic cancer if you were to only employ NGS type assays and you don't look at protein expression by our good old IHC. So good news here is we as pathologists are very much in business and by looking at protein expression, and HER2 still remains the domain of surgical pathology and not of molecular pathology. So here's some additional data of HER2 overexpression, which can occur even in the absence of HER2 amplification. The numbers here are based on analysis of 723 examples from diverse cancers, including non-small cell lung cancer, breast cancer, colon cancer. And what you can see is that amplification events that coexisted with IHC overexpression occurred only in 55 events, while there were 122 cases, almost 2.5 times cases that were IHC 2 plus and 3 plus. And the same thing occurs in other studies too. As you can see in the right, IHC 2 plus 3 plus was 26%, while the amplification was only in 2%. Clearly bringing home the message that protein expression is something that we should actively be looking for and not depend upon molecular assays for analysis of HER2. So what are the scoring systems that are around? There are multiple scoring systems, and I'll stop here for the polling question. If you don't mind answering that, what are the scoring criteria or which scoring criteria do you use for scoring IHC outside of breast and gastric tumors? Okay. Okay, looks like results are stabilizing a bit, particularly when you're looking at the pattern. We have a very stable result of around 50%. Where people say they look at HER2 3 plus must exhibit strong complete circumferential / basolateral U-shaped staining or lateral membrane staining of greater than 10%. Then there are few 30% of people who think that must exhibit intense complete circumferential staining greater than 10%. And then there's a slightly smaller number about U-shaped staining or lateral staining greater than 30% of tumors. And suffice to say that this highlights the current state of understanding, where we need to improve our understanding of which guidelines one should use. So let's look at some of the guidelines that exist. So here's the classic story of HER2. We look for a number of different things. We look at the staining pattern. The control should be completely negative, while the staining patterns in the tumor cells are the three patterns that we already talked about: circumferential, lateral membrane, and the U-shaped basolateral membrane staining. We also have the percentage of cell staining, 10%, 30%, and 50%. Yes, there are some guidelines that do recommend 50% staining, and we'll talk about that a little bit more. And then, of course, we have the intensity of staining, where we need to have strong membranous staining for most purposes. But then, as we all know, there may be lighter degrees of staining in multiple other cancers, and the terms HER2 low and things are becoming quite prevalent. Again, we are not going to talk any more about that today. Okay. So another polling question: for which tumor types, in addition to breast and gastric, does your lab perform HER2 testing? So good. The vast majority of people are talking about endometrium, colorectal cancer making a rapid advance there. Same difference. We just and again, we are just trying to build knowledge base about what the practices are. And obviously, many of you are testing in multiple cancers. So yes, a point is well made that we could have all others. But we could say other solid tumors. That could be all, but point noted. Okay, so endometrium, colorectum, ovary are the main ones. Bladder somehow doesn't seem to be much. Biliary tract is again something that we need to highlight. Cervix is another very important target. As you will see, as further data develops, those patients may have a good response. Again, the data is too early to comment about today, but something to look out for as the data develops. Okay, so clearly we have the ASCO-CAP guidelines that talk about the scoring systems for breast and gastrointestinal cancers. We talk about a 10% cutoff on excision specimens for both the tumor types, while the biopsy guidelines for gastric cancers are slightly different. So we won't talk about that. Just keeping it in more generic terms, we're talking about 10%. For those of you who don't know, the gastric cancer guidelines basically require, on a biopsy, a single cluster that shows strong, intense membranous positivity. It's enough to call it positive. And a cluster is defined as a group of 5 cells. So whenever I think about gastric cancer, I see the stop sign saying stop, 5 cells is a cluster, and that's all you need for defining something as positive. So difference in patterns are kind of well recognized. In HER2 breast, we always talk about strong membranous circumferential staining, while in gastric cancer, it's more typical to have circumferential, basolateral, or lateral staining patterns. So this is the well-traveled path. But outside of that, We have other trials, such as the FEDER clinical trial, that used 30% guidelines for selecting patients with endometrial cancer for therapy. The Hercules trial in colon cancer used 50% as the cutoff for selecting patients for therapy. So clearly there are differences in the variety of cancers as to which guidelines people use. And then we need to have some coming together of minds so that we have a more standardized guideline that is used across multiple cancers. So again, this is more of a figurative illustration of something that we talked about a second ago. So as you can see in the breast, we have complete circumferential staining greater than 10%, while in gastric cancer, we have on an excision specimen greater than 10%, basolateral or lateral is sufficient, while in a biopsy, we had definition of greater than 5 cells. A single, so they can't be scattered, they have to be a cluster. That's the only thing to remember, but it has to be 5 cells or more. So fairly straightforward. As we come into the colorectal cancer, here's the slide showing the greater than 50%, again shown as a representative example. And this is data showing that different people use different guidelines when scoring cancers beyond breast and gastric cancer. So vast majority of the people use gastric cancer guidelines for other cancers. Some people still use breast cancer guidelines, and then 30% of the labs use the colon cancer guidelines of 50% or more. And clearly, we need to come to a more rational definition that is useful across the board for when looking at colorectal cancers. So what do you guys do when you are doing colorectal tumors? Wonderful. I do not perform IHC testing. That's the majority. Okay. So the good news, maybe I spoke too. Okay, so we seem to have a fairly stable answer. 56% of the labs do not do any staining. Those who use, the vast majority use gastric cancer. Few labs do use the Hercules trial, 50% cutoff. Very few labs use the 4%, the breast cancer cutoff, and then some others use other. I have no idea what that number looks like. Okay, so that's again another 4%. So what I'm going to tell you more is maybe we should not be using breast cancer guidelines outside of breast cancer. Breast cancer guidelines are great for what they do in breast cancer, but we need to kind of focus much more in terms of colon cancer on gastric cancer type guidelines, because those seem to be much more effective in selecting patients. And again, these data are developing, so watch the space. We may not need 50%. So let's do the similar exercise for endometrial cancer and see, again, these are what we have in terms of the various guidelines that are there. Recap: breast 10%, greater than 10% circumferential. The FEDER trial guideline had 30% complete basolateral or lateral, while the ASCO-CIP guidelines have greater than 10% on excision biopsy. So the question that comes up, again, HER2 membranous staining at low magnification. And that's one point that I really want to drive home, that if you have 3+ staining, you should be able to see something like this at a 4x magnification. If you can't see it at 4x magnification, you should not call it 3+. This should be very apparent at 4x magnification. The lowest magnification, some people have a 1x, but low magnification, you should be able to see this kind of a membranous staining. If you have to go to 10x or 20x to see membranous pattern, you're not talking about a 3+ staining. The other point, of course, is the color. You have a 3+ staining is more like this, a mahogany brown, not the golden brown that you typically see in 2+ and 1+ staining. So just remember some of these things. Whenever you are in a doubt, if you can't convince yourself, it's not your skill that whether you can see the membranes or not, if you have to squint or not, it should be obvious to any Tom, Dick, and Harry. Something like this. Anybody who looks at this and says, yep, this is membranous staining, it's strong, it's complete, this is 3+. Okay, so just remember that when you are thinking about whether to call it 3+ or 2+. Okay, so polling question. What scoring criteria do you use to determine HER2 positivity in endometrial tumors? Do you use the 30% guidelines? Do you use the 10%? Do you use breast guidelines, the gastric guidelines? Do you use something else? Do you not perform anything at all? Again, as you can see, we are collecting a lot of information here. Okay, the results seem to stabilize a little bit. So 35% or a third of the people don't seem to be doing the staining. When they do the staining, they're using the gastric cancer guideline, 10%. Few are still using the breast cancer guidelines, and then a very small percentage are using the FEDER trial, 30% or more guidelines. Okay. So that's the problem, right? We really do not have any national guidelines, whether it's ASCO-CAP or any other foundation guidelines for beyond breast and gastric cancers. There are suggestions as to which guidelines should be used, but we do not really have a coming together of minds. There have been some clinical trials performed using some cutoffs, and those have been typically the gastric cancer cutoffs that have been used. But again, there's no pan-cancer endorsement of guidelines to the best of my knowledge. I can see some heads saying, no, they are. So let's talk about that later. Anyway, so what do we do in terms of reporting some of this? And the problem basically is, if you use the wrong guidelines, you will start getting different results from the neighboring lab. And we always have to keep up with our neighbors, because the last thing you want is the slide going across to the teaching hospital or to the other community hospital, and they say, nah, what they did, they don't know what they are doing. That's the last thing anybody wants to do. So let's look at some of this in a little greater detail. So the problem is, when using ASCO-CAP HER2 guidelines for esophageal cancer, IHC 3+ was reported in 11 to 12% of cases. When the same cases were examined by breast cancer guidelines, only half of the cases seem to be positive. And that's really where the problem arises. That although prima facie, the scoring systems seem to be fairly similar, because a large percent of cases are being tested on biopsies, you are going to have a major difference, because on one you want the 10% of cells, while in others, a cluster of 5 cells or more is considered sufficient for positivity. Same thing in lung cancer. the IHC reactivity closely resembled those of gastric cancer, and so most people tend to use the CAP, ASCO CAP, ASCP, whatever gastric cancer guidelines for that. Okay. So HER2 testing is a part of the CAP biomarker reporting templates for multiple cancers. And these are the various cancers for which the template has been used to a variable extent. So in breast, gastric, colorectal, lung, endometrial, there is specific mention of HER2 IHC testing, while in some of the other cancers, there is a generic IHC template available for analysis. And again, there are QR codes here, links to the appropriate testing. And this is what the template looks like. We want to have positive, negative, equivocal, cannot be determined categories in terms of interpretation. We have the scoring systems, whether you use the scoring system of breast, gastric, or others, percentage of positive cells. And then, of course, we want to talk about the IHC testing methodologies that were used, whether the controls were normal or they did not show any immunoreactivity, the type of antibodies used, the assay information, whether it was a LDT or a non-LDT, and then the specific quantitative imaging analysis, if any was used. So another polling question here. For which tumor beyond breast and gastric are you currently using general IHC biomarker template for HER2 testing? I love these people. Okay, so the vast majority do not use this template of any sort. So they probably use a freehand method if they do the testing. Maybe a significant reason for this answer is that many people are not testing for HER2 beyond the breast and gastric cancers. So that could be one reason why people are not using a template. Endometrial cancers and ovarian cancers seem to be high on the list of people testing for it and using templates of sorts. Colorectal cancer coming next, biliary tract, and cervical cancer. Again, the GYN folks are helping us out here with a few cases of bladder and non-small cell cancers and other solid tumors. So clearly the message about HER2 testing in GYN cancers has penetrated in this audience far better than testing in some of the other cancers. So that's good news. Okay, so let's go on to the next slide. So this is really a very generic statement about a pathology report. A pathology report, in simple ways, is a communication between us as pathologists and our clinicians. So I do not try to be very fancy with my pathology report. I try to make sure that the clinicians understand it. If I make a rare diagnosis, I make a point of calling them up and saying, hey, I'm sending a report which has got some funny words that you are not used to it, and this is what I mean by it. And this is what may be the right way to manage it. Of course, I never, ever dare to tell them how they should manage it. But they don't have a clue, and we suggest to them. So similarly, we should have details about how the testing has been done and what were the considerations that you put into it. It's so simple things like pre-analytic variables. All of us have been doing it since the ASCO CAP guidelines came in for HER2 testing more than a decade ago. So simple things there, cold ischemia time, type of fixative. And again, this becomes important because remember the old days when we said we have to use formalin. We cannot use alcohol because alcohol preserves the HER2 protein better. And then we had variety of algorithms that were devised to somehow say which 2+ is or 3+ is real 3+, and which were not 3+. And if you had staining in normal, that was horrible, and we needed some algorithm to do that. And again, there were a bunch of papers in a variety of journals about it. Maybe you guys are most of you are too young to look at it, but there were papers. Anyway, so we need to talk about that. We need to talk about whether there was decalcification or not, because some of the assays are not FDA approved for decalcified tissue, and we need to issue disclaimers when appropriate. We need to talk about the primary antibody use. We need to talk about the analytic variables, including what were the reasons for calling something inadequate for testing, or do we need to repeat the testing because the controls were not there? And then general consideration that apply to anything and everything, communicate actively to clarify different aspects of the report. And this was a point that I particularly used to make with PD-L1 and things like that, where we have a very nicely defined cutoff. Even here in HER2, we have a 10% cutoff that is used. So if you have a 9%, say that you think it's 9% and not 10%. If you think it's 11%, say it's 11%. Because if I see a slide coming from outside and they're calling it positive, and I'm like, well, I'm not sure about this. But if you have called it 10% or 9%, then I'm sure that, okay, you are in the right ballpark. Yeah, there are slight differences in estimation, and we can explain it that, okay, fine. We are all together on this. But if you just say that something is positive or something is negative, the second pathologist who is looking at it doesn't have a clue what was going on, whether you thought it was 9% or 0, and all of those kind of things, or 11% or 100%. We don't have that kind of differential there. So putting somewhere in the report as to what percentage of cells you were thinking were positive, particularly in those borderline cases, is extremely useful, so that the second pathologist has a greater chance of agreeing with you, because no one is going to dispute you between 11% and 9%. If I'm at 9%, you have called it 11%, or vice versa, I'm going to agree with you. But if I have no idea, I'm less likely to agree with you. So there's several key considerations in HER2 testing that we need to talk about. Again, principles of analytic validation of IHC. Scoring systems need to be validated. The assay scoring systems for colorectal cancer, currently at least, are at the discretion of the laboratory, but most people are starting to use the gastric cancer scoring guidelines. We need to use validated assays. Again, colorectal cancer and other cancers are becoming increasing a problematic issue because people are not quite clear what to do. There are some clinical trials that are coming out. Some of them are positive, and they seem to be using the gastric cancer guidelines, but the data is too early for us to talk about at this particular forum. So we need to wait and watch as to what's going on. But by and large, there seems to be a shift towards using gastric cancer guidelines across the board for multiple cancer types. Remember, biopsies and resections are scored differently. You need to have a validation of the assays that you use with 20 positive and 20 negative cases. And then if you have validated for one tumor type, it's okay to carry it onto other tumor types. So the key takeaways are HER2 is overexpressed in many solid tumors beyond gastric and breast cancers. IHC positivity should be assessed separately, whether or not you look for DNA level alterations in terms of amplifications or mutations. HER2 testing guidelines and scorings are evolving, and we need to pay attention to which guidelines to be used, what tumor types should they be used in. And again, a lot of this data is coming out. Most of it is in the clinical arena at this time in terms of clinical trials, but They are going to start percolating into the pathology literature very soon. And we need to kind of group together so that we have a better way of doing it as a consistent method across the board. And again, the gravity seems to be towards using the gastric cancer guidelines across the board. But again, watch the space. Pathology reports should emphasize consistencies and be providing as much details as possible. And then scoring guidelines can vary. So tell us the details as to what you're using. And then, of course, the AstraZeneca and Daiichi have developed this website known as HER2 Know, where there are whole slide images, consensus codes, cases, studies, and a number of other resources that are available. And this is, I'm no interest in it. I'm not a part of this particular website, so I'm not particularly promoting it. But this is a resource that the companies have made available for all of us to use so that we get better knowledge of what the state of the art is. And lastly, there's some feedback. Thank you for your time and attention, and please feel free to comment. I don't think these results will be posted on the computer out here. So that's kind of the end of the presentation. Feel free to ask me questions. Should I go on to the next slide? Or yeah, there's a microphone.
Hi, Dr. Bobby. Thank you very much. I'm Mike Dugan. I'm a pathologist that does consulting for a lot of biotech companies now. But in 1997 at Wayne State, I published a paper on HER2 in pancreas cancer. And it's been really interesting to see the evolution over that time because at the time, as you recall, in breast, the FISH was much more objective than the IHC. And so IHC was, although it had been published as present in a lot of tumors, it was discounted as probably nonspecific background staining. And only the FISH was held up as the gold standard. What you pointed out are the two different things are scoring criteria, which I think are very important, as well as sensitivity assay is very important. And those are sort of separate. For example, when I think it was Pfizer came out with an ALK inhibitor in about 2009, 2010, there was a cutoff established for FISH at 15% alteration. But it sounds very precise. It really wasn't. All it was 3 out of 20 cells, which was the way to count manually and be convinced it was at least three cells sounded positive. If you did an automated image analysis, you could see FISH alterations at a level of like 1 or 2% quite easily. So that was scoring criteria based on method. And the other example is, related to the sensitivity and what threshold we're going to use is really related to the therapy efficacy, right? So back in the old days of trastuzumab, they didn't want to treat somebody that was 1+, 2+. They didn't see very much response. But with the new antibody drug conjugates like in HER2 or TDXD, the generic name, they could see the responses in the very, very low levels. So then the question becomes, in like the things that are even below 1+, 0, or ultra low, whatever you want to call it, there's been responses seen in some tumors. I know it varies across the different tumor types, but that begs the question of, is even IHC adequate as a method in terms of sensitivity? And you could use all the image analysis you want to in the world, and you're not going to improve the sensitivity of IHC. So I'd really love to hear your thoughts on that if you can talk about it. If you can't, we'll talk later.
No, happy to talk about it in generic terms. So IHC is not the greatest assay in the world. We are using an assay that was developed to identify 3+ positive cases. And in fact, we were so worried that we wanted a formalin fixative rather than alcoholic fixative because we wanted some degree of protein degradation to occur because of formalin, right? So all of that is well established that we are not using an assay that is fit for purpose. The point, however, is this is the assay that we have. These assays have wide penetration. So can they be repurposed to the extent possible so that we are not starting from level 0, we are starting at a point where we know that FISH amplification mutation don't seem to identify patients who are going to be responding. So we have one assay that works relatively well. Should we be all going to fresh tissue and fluorescence and doing 3D imaging? Well, that's one idea, but it will cost us enormous amount of time, energy, and AI and everything else to get to that point. And the question is it worth getting to that point? Are there simpler methods? So there are multiple people, very smart people, trying to look at these kind of questions. And the dust is yet to settle. We are where we are today. 20 years since we started HER2 testing, nobody can really give me an answer why we have a 10% cutoff. What happens if you have 9%? Do those patients respond? The only answer that I have gotten from some older folks is that the 10% was where the Hercept assay had the best concordance with another older assay, which was the clinical trials assay. And that's the origin of the 10% cutoff that everybody uses. So is there any science behind it? Answer is no. But on the other hand, we have the B47 clinical trial, which was for HER2 normal, that is not overexpressed, not amplified patients who were treated with trastuzumab, and those patients did not respond. So clearly, the new drug combinations that we have seem to be very potent at picking up patients or showing efficacy in patients who have very low levels of HER2 expression. How low is low? We still don't have an answer. In breast cancer, the things are evolving a little faster than in other cancers, but there are a number of clinical trials. Most recently at ASCO, the data from Destiny-06 was presented, but the numbers are small. 75 patients in each arm. So the really small number of patients. So we have to wait for other trials. There's the Destiny B15 trial going on, which is talking about HER2 normal expression. So that is not even the tiniest bit of expression there. So a lot of these things are developing as we speak. And as the data becomes mature, as the data becomes verified in larger number of patients, we have a problem that we need to fix in terms of the testing methods that we use. Will we be doing HER2 testing at all in 5-10 years' time? I don't know. If Destiny B15 is positive, maybe in breast cancer we may not be doing testing. So there are so many variables. And we are still talking about one drug that has come up in terms of an antibody drug conjugate. There are several others that are trying to compete with the companies that I'm speaking for today, that are trying to do exactly the same thing with an antibody with a different conjugate. And all of that is, who knows? For them, the cutoffs may be different. One may need 50%, other may need 10%, other may need 5%. We have no idea. I wish I had a crystal ball that I can predict some things, but I don't. And so we have to just wait and watch. So sorry to give a very long-winded answer for your question. Abigail, we have two questions. One here next to Dr. Dugan, and then Dr. Jain there.
Thank you very much, Dr. Badvi, for your educational talk. Dr. Jeff Craver from St. Louis, Missouri. We have a number of pathologists that want us to consider bringing in HER2 testing and IHC testing on solid tumors other than breast and gastric. And as a person that helps evaluate the validity of those, that HER2 testing, we had 20 positive and 20 negative breasts, and 20 positive, 20 negative gastric. That's a lot of work.
Yeah.
You showed a slide indicating there's another way you can go about validating the other solid tumors, but I'm just uncomfortable with that. You were talking about a prognostic indicator.
A predictive indicator. More than prognostic, a predictive indicator.
Predictive indicator, excuse me, yeah, you're correct. Just with endometrial cancer, there's different subtypes of it, although with breast cancer, there's different subtypes, and we haven't validated it against every single one, just the lump sum tumor entity. I would appreciate if you could show that slide again. You had a QR code that talked about, it was a link to how you could validate the other tests or the other cancers. I'd like to use that as a reference. And do you test against all these tumors in your own lab, the other
Yeah,
side?
that's one of the points that's made. The last bullet point here is that if you have an assay that is validated against one or more tumor types, then you can expand the indications as you start going ahead. The second point is everybody is very, very nervous about what to do in here. The companies that I'm representing, I'm speaking for today, included, they are not going gung-ho and say, hey, use this, that, because they are also a little unsure because the data so far is very limited. They were done in some central labs across the world, samples. There were metastatic tumors as well as primary tumors. So a lot of variables in terms of fixation, processing, everything else. So nobody is quite sure as to where we should be. And that's the reason at the end of this talk, I have not given you a specific answer. Go ahead and use the gastric cancer guidelines. I have not said that because there are a lot of these questions that are still up in the air. The trials have used the gastric cancer guidelines, so that's the reason most of us are gravitating towards them. But are those the only guidelines we should be using? Nobody has a clear-cut answer. So watch the space. I think this is a very rapidly evolving area, and we are all nervous about saying anything because whatever we say today might be completely wrong in 6 months' time. Breast cancer is a classic example where the scale has been sliding very rapidly. And they're even talking about, as I said, the DB15 trial, which basically says, even if there's nothing, that seems to be fine. And that's, again, data coming out from the DAISY trial that was based on brain metastasis, and the numbers of those patients were like 20 or 30 patients that, in spite of having no detectable HER2 with the current assay, seem to respond to anti-HER2 therapies with the novel drugs. So watch the space is a simple answer. There's a lot of data, but I don't think we are in a position today to generalize and put together guidelines as to this is what we should be doing. The data seem to be percolating. We need to digest it, let it mature before implementing it in clinical practice. So Mike. Okay.
Conservative resisting push to doing HER2 on other solid tumors and just say, well, we send this off for molecular testing in a reference lab, and they'll evaluate it for a genomic HER2 mutation. So, and the oncologists seem to be happy with that right now.
A lot of those things are happening, but that's the reason to emphasize that what we are doing in our labs in terms of IHC testing has significant value. So we shouldn't be farming it out to the foundations or whatever else of the world. No offense to anybody who may be representing those companies, but we need to be careful.
Exactly. Don't assume that the NGS on plasma ctDNA is the same, because the copy number variations are very easily diluted by germline. Correct. So that the cutoffs there are completely different. Yep. And look back to pathology 20 years ago, because we held up FISH as a gold standard. They didn't treat pancreas cancers with trastuzumab for literally 15 or 20 years because they rarely saw gene amplification, when actually those patients did respond in metastatic, or advanced pancreatic cancer. They did respond to trastuzumab. So the drugs are sometimes more effective then what we realize, and our own diagnostic criteria might inhibit the choice of a therapy that could be effective. That's the takeaway.
So there was a question here.
Thank you for the excellent talk, I suppose. I was all confused about this, and I'm a GI pathologist practicing for 10 years. We do quite often on upper GI junction cases, all the time HER2. But recently we started getting requests for colon. And as you said, we can send it out, but we don't know what their positive and negative is. So I just want to ask you regarding the question, if we want to bring it in-house and do HER2s on those colon, do we still validate our HER2 immunohistochemical stain, which we are already using for breast or G junction? First question. And second question is, if I do report colon, is it okay just to report percentage of cell staining basolaterally and let them decide positive, negative, and HER2?
The latter question is much easier to answer. Definitely give the data and let the clinicians answer, because different clinical trials may have different eligibility criteria. And we don't know what trials, what drugs are coming down the pike. So giving them data and letting them decide what they want to consider positive is a good way to do, so that you can never be wrong about it, because just providing raw data. The issue about validation across different cancers is a much more complex issue. Some people say that, well, if you have a validated assay for breast and gastric, you can use it across the board for colon and everything else. That's what a lot of people are doing. Whether that's a right or a wrong answer is yet to be determined. We don't have a national guidelines really in that space. So what we have is individual cancer-related guidelines. And there is spillage across different cancer types, and people are using what they're comfortable with. So very difficult question to answer. Whatever I say might be proved wrong by some committee or the other in the near future. So use what you think is best. Most people tend to use the previously validated breast and gastric cancer IHC assays for the remainder of the tumors.
Sorry, but one last question.
Sure.
Is HER2 mutations on NGS is equivalent to HER2 overexpression?
Absolutely not. That's a simple answer.
Yeah, so they just request it all the time when they see the mutation.
Correct. So,
but treatment is based on mutation
No.
or overexpression?
Overexpression. So the new drugs, let's back up for a second. The old drugs were fairly simple, right? You had an antibody that attacked the tumor cell, and then because of the antibody combination with the cell surface protein, you had activation of immune responses of one sort or the other things. You had blockage of the function of the receptor, HER2 or PD-L1 or whatever. So those were the simple therapies that were allowed. So imagine a situation where not only we have the antibody, but we have the antibody with an attached toxic substance. Okay, so just to use a figurative analogy, previously we were ramming the cell with a truck, which was empty. Now we are loading it with explosives and then ramming the cell with the explosive, and the truck goes in, rams it, and boom. What happens now is with many of these new drugs is they not only kill the cell that has the expression, but they also allow the toxic drug to seep. And as the old saying goes, there goes the neighborhood. And that's what happens. So there's a lot of bystander injury to adjoining cells. So low levels of expression seem to be sufficient for these novel drugs to act, because they are not only acting by the immune-related mechanisms or prevention of the protein from functioning, but in addition, we have the toxic chemotherapeutic agent which is attached to the antibody drug. And just to give an example, the first version of it had 3 or 3.5 molecules per antibody. Current versions, the TDXT that was just said, has 8 toxic molecules of chemotherapeutic agent per molecule of antibody. So with these kind of uploading of toxic chemotherapeutic agent, we are delivering a more targeted chemotherapy in addition to the immune and everything else that was previously being done by the antibody itself. So that is increasing the efficacy quite dramatically. Couple of questions. Okay.
Yeah. Hi, Pavel Mroz, University of Minnesota. I'm actually a molecular pathologist. I do not look at the slides for HER2, but we do have ERBB2 on molecular tests. And I think just a comment, I think the molecular is coming after HER2, and part of the reason is that when you talk about, so the discrepancy that you showed between, the IHC and FISH and mutations, obviously FISH will not pick up the mutations, right? It will just pick up the ones that are amplified. And those are probably the ones that are most closely correlating with your strong staining. If you have like a proper amplification by FISH, there is a higher chance that you have enough protein overexpressed that it will be positive by IHC. But once you go to the mutations, you have whole spectrum of mutations depending which domain it hit. You can have activating mutations in tyrosine kinase domain in HER2, which will not translate into increased number of protein. It will just translate into the increased activity of the gene, which may respond to, small molecular inhibitors and not necessarily, the antibody that targets the expression of the protein on the membrane. And then you're going to have inactivating mutations. Quite few of them are actually inactivating that will not have that. And then on top of that, the complexity with HER2 is that a lot of those mutations are concurrent with amplification. So you have a lot of HER2 that is amplified and also carries some sort of mutation in it. And some of those mutations may actually nullify the effect of amplification. So I think molecular is coming after this because we now have DNA assays that are starting looking at copy number, and we're also doing a lot of fusion of RNA, and we're seeing amplification and increased expression based on an RNA. But I agree with your comment that IHC is the assay that has the most penetrance. Everyone can do it, and I think so for the foreseeable future, we're going to start.
So you have made several points, okay? The first point, and I agree with you on that, is these are not mutually exclusive assays. The mutations, particularly the activation mutations, those patients could still benefit from small molecular inhibitors. No doubt about that. Could is a very important word. Okay. The second point that I really want to make is if you have a tumor that is amplified, a portion of it is necrosed, and gives rise to the circulating tumor DNA, you might detect the DNA to be amplified or mutated. But if you were looking at the same assay, the same tumor with FISH, because it doesn't meet the criteria of ratio of greater than 2, you would say they're not amplified. So every assay is constructed differently, and we need to be aware of the limitations and the utility of those assays. So point mutations for HER2 have been described, particularly in lobular carcinomas and multiple other cancers, still might benefit from small molecular inhibitors. But what we are talking about is a larger population where we have various degree of protein expression, and we have a novel therapeutic that could be used for that. And so we don't want people to stop by saying, okay, the mutation rate is only 2%, not quite worth testing for it by IHC. So the equation is now flipped. And the same thing happened a few years back when the TOGA trial results came up, which showed that IHC of 5 cells was considered positive, but FISH you still needed to do the 60 cell count. And people who was doing cytogenetics started complaining, saying, hey, what's going on here? Do you have 5 cells and you're comparing us with 60 cells? And those of us who did IHC said the same thing. You talked about, you never complained when it was breast, when you looked at 60 cells and we were looking at 10% of the tumor cells. Yes, so every assay has limitations. The point being made is, don't stop with one assay because there are multiple ways of skinning the cat. Now, why one would want to skin a cat is a different story, but that's there are multiple assays. Use them wisely to select the best possible therapy for your patient. I think that's the moral of the story. Let's not fight as to whether IHC is better or FISH is better or NGS is better. They all have utility. It's just a question of agents require different testing and making sure that low levels of protein expression or cancers that we didn't think as traditional targets for therapy should be considered as targets for therapy is really what the message is today. There were questions, comments? Okay.
Can you please comment on EDTA decalcification and HER2 overexpression?
That's been a problem for a long period of time. And every time we do decalcification, we write a love note saying, the specimen has been decalcified, we cannot guarantee the degree of expression.
Is that true for EDTA also?
Don't know. I don't think we have solid data on EDTA. Anytime we have decalcification, no matter which decalcification agent is used, we are on thin ice.
Okay, because EDTA decalcified specimens are being used for molecular study.
Oh, totally. I agree.
Okay.
Again, there are ways out. You use the blood clot, you use the portion. If you can avoid some portion to be decalcified, use that soft clot and hope that there's tumor cells. You can always play some tricks there, but there's no guarantee of the quality of staining if you have a decalcified specimen.
And we specify in the report.
Correct. Yeah.
Thank you.
Okay, Mike, you have the last word.
The question about the mutations and all the variations that you can get, copy number variations, mutations, and so forth, really important. But realize a lot of those were established in lung, right? Where in the lung, the practice was using NGS to find things like EGFR, ALK, so forth. And it wasn't, because they saw the EGFR mutations, then they tried some of these drugs in those patients using that as a selection criteria, but it's a different selection criteria than the IHC in breast. If you go to all the breast literature, there was nothing on NGS. So they don't have that until recently. So there's just, the trials have established the predictive value of the different tests with different thresholds. And if we hold up one as a gold standard, we're probably, like you were saying, we're probably missing a bunch of other opportunities for treatment in patients where it might be effective with these newer drugs. And that's the only point I was trying to make earlier, is just don't regard one test as the gold standard and rely on just that the value of the test is based on the therapeutic trial that establishes its predictive value.
Very succinctly said. So thank you very much. We may be out of time, so thank you very much again for coming here, and thanks. Pleasure.